Audio Jungle. Audio Jungle. Audio Jungle.
The pathogenesis differs between women and men. In women, a UTI develops when urinary pathogens from the bowel vagina colonize the urethral mucosa and ascend via the urethra into the bladder. Risk factors include being female, previous urinary tract infection, or sexual intercourse. Urinary tract infections are uncommon in men. They're usually secondary to a structural or functional abnormality, most commonly prostate enlargement.
Now, a urinary tract infection, or UTI, is any infection of the urinary tract, which includes the upper portion of the tract, the kidneys and the ureters, and the lower portion of the tract, the bladder and the urethra. So cystitis, when it's caused by an infection, is a type of lower UTI. Lower UTIs are almost always caused by an ascending infection, where bacteria typically move from the rectal area to the urethra, and then migrate up the urethra and into the bladder. Having said that, on rare occasions, a descending infection can happen as well, where bacteria starts in the blood or lymph, and then goes to the kidney and makes its way down to the bladder and urethra. Normally, urine's sterile, meaning bacteria doesn't live there. The composition of urine, which has a high urea concentration and a low pH, helps keep bacteria from setting up camp. Also though, the unidirectional flow in the act of urinating also helps to keep bacteria from invading the urethra and bladder. Some bacteria though are better at surviving in and resisting these conditions, and can stick to and colonize the bladder mucosa. E. coli accounts for the vast majority of UTIs. Also though, other gram-negative bacteria that can infect the bladder include Klebsiella, Proteus, Enterobacter, and Citrobacter species. On the other hand, gram-positive bacteria can also cause problems, like Enterococcus species and Staphylococcus saprophyticus, which is actually the second most common cause overall after E. coli, and particularly affects young, sexually active women. Urinalysis is done, there might be signs of inflammation like pyuria, the presence of white blood cells in the urine, which can make the urine appear cloudy. Having a couple white blood cells in the urine can be normal, but it'd be considered abnormally high if there are more than 5 white blood cells per high-powered field on microscopy, or more than 10 white blood cells per milliliter on a hemocytometer. Similarly, a dipstick test might show the presence of leukocyte esterase, which is an enzyme created by leukocytes, or white blood cells. It might also be positive for nitrites, since gram-negative organisms like E. coli convert nitrates in the urine to nitrites. But it's worth remembering that not all uropathogens are able to do that. Alright, and finally, a urine culture is the gold standard for diagnosis, and is considered positive if it shows more than 100,000 colony-forming units per milliliter from a clean catch urine sample. Although a lower number of colony-forming units per milliliter might still indicate an infection, depending on the source of the specimen and the specifics of the clinical scenario. And remember that this test assumes that the bacteria that grows is a known bacterial cause of UTIs, and that the patient has clinical symptoms. Now, if there's pyuria but the urine culture doesn't reveal a bacteria, this is known as sterile pyuria, and it suggests urethritis, inflammation of just the urethra, as opposed to cystitis. Isolated urethritis is most commonly caused by Neisseria gonorrhea and Chlamydia trachomatis, both of which are sexually transmitted infections. For a UTI, imaging studies can also be helpful. For example, a renal ultrasound can be used for children who might have a kidney malformation, which could contribute to developing a UTI. In addition, a voiding cystourethrogram, or VCUG, might be used, which is where someone's given a radiocontrast liquid and fluoroscopy, which are like real-time x-rays, and then they watch how that fluid gets urinated out. and this is particularly helpful in children with severe or recurrent UTIs to detect evidence of vesicoureteral reflux, which is the retrograde movement of urine from the bladder back up into the ureters and kidneys. The degree of vesicoureteral reflux can vary, and it's an important risk factor for kidney scarring with a UTI. Finally, in some situations, renal scintigraphy using DMSA, which is a radionuclide, sometimes called a DMSA scan, can be used to detect evidence of kidney scarring,